Dawn, I need my slide back, please. We're going to get started in a few seconds. I just want to give people time to come in from the waiting room. Okay, so we're going to get started. I'm Judy Krasna. I'm the Executive Director of F.E.A.S.T, and I'd like to thank you so much for joining us today. Before I introduce our speaker, I just want to go through a few housekeeping items. So the first thing is, please take a moment right now and make sure that your camera and your microphone are off, and please make sure that they stay off throughout the duration of the webinar. And if you have any questions for Dr. Locke throughout the presentation, just pop them in the chat box and we'll get to them at the end. And now it's my pleasure to introduce today's speaker. James Locke, MD, PhD, is the Eric Rothenberg, MD Professor and Senior Associate Chair of the Department of Psychiatry and Behavioral Sciences at Stanford University School of Medicine. He is the Director of the Eating Disorder Program for Children and Youth at Stanford Children's Health. He is best known for his work engaging parents and families in helping their children overcome eating disorders using family-based treatment, FBT, including anorexia, bulimia, and ARFID. He is the co-author with Daniel LaGrange of Help Your Teenager Beat an Eating Disorder. On a personal level, Help Your Teenager Beat an Eating Disorder was my Bible, and I can't describe how much it educated and empowered me to care for my daughter. So it's really an extra special privilege for me to have Dr. Locke here with us today. And now, Dr. Locke, you can get started.
Thank you so much for that introduction. I cannot share the screen yet, though. Can I now? Let's see. Terrific. Thank you. Judy, that was such a kind introduction. Thank you. And I'm glad the book was helpful to you. That particular book, Daniel and I wrote based on our clinical experience working with families and trying to help them over many years. It's been translated into about 10 languages, I think, at this point. So it's available lots of places. And thank you for the opportunity to speak with all of you today. F.E.A.S.T is an organization also dear to me because it was an outgrowth to a certain degree of family-based treatment. When we started the work in the early 2000s, there were really no parent organizations that were operating quite the way that they needed to for adolescents advocacy and in mental health and eating disorders. And the first one was mostly parents, and then F.E.A.S.T was the next one that developed, and there was a lot crossover between those two organizations. And I have appreciated the work that so much that the parents in both those organizations have done and are doing to help move us along. Today, I'm going to be talking about innovations that we're working on in trying to improve access to care to families whose children have eating disorders. And so I am funded by the NIH as well as a few other foundations, and I have ownership interest in the Training Institute for Child and Adolescent Eating Disorders, which basically trains clinicians in FBT and related therapies. So today I'm going to talk a little bit about guided self-help approaches and why they should be considered as part of what we might be providing to families. Talk then about some work we've done piloting this approach, and also about the feasibility of doing a randomized trial for using the approach to see if it's actually sustained in terms of a validated treatment, and then some innovative use of this approach for children on waitlist. So why guided self-help? Why do we need it? There's a huge gap between what we have available in terms of resources to treat children and adolescents with eating disorders. If you're in an urban area in a major city, you're likely to have a program that provides care for eating disorders in youth. But If you're in another location outside of a major city, you're less likely to have such a program. So if you're in a rural area or, for example, or on the outskirts of a major area, you may have to drive a couple hours or more just to get to care. Second, um, there's a high cost and burden to traveling to these specialized locations. And even though video conferencing can make some difference, the provider pipeline itself is insufficient, meaning we don't have enough mental health professionals who are going to be trained and available, even if we could find a way to access them. So looking for another strategy where there's less professional and provider requirement to participate is almost a necessity. And not and we can say this clearly even in the US or say Canada, but if you go to say somewhere like China or Japan, you will find so few providers that this becomes absolutely something you have to think about. And when I was in China before COVID, I visited 2 units, one in Shanghai and one in Beijing, and the kids there were just the same as the kids here who have anorexia and look the same and behave the same. And when you think about the scale of China and the fact that there are 2 15-bed units in the entire country, then you get a sense about what I'm talking about in terms of this gap. Also, there are challenges in trying to disseminate family-based treatment itself. It costs money to train people, to individuals, to healthcare systems. There's a lot of turnover in professionals. They 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 leave the field or they work part-time. So it's an ongoing issue of implementation and training. So having a different strategy, which requires maybe less training on the professional part and fewer professional resources, is something that might help stem some of the tide. Another issue, which Judy and I were talking about a few minutes before starting today, was that there are lots of things people call family-based treatment, but it isn't. And FBT is actually a pretty specific treatment, right? So it's manualized, it's got very specific timings and expectations about what the therapist should be helping families do. And unfortunately, therapists often wing it and do things on their own and invent and modify the things. And this lack of fidelity to the manual leads to problems in terms of families not getting the help that they should in the way that they should, and outcomes being not the same. So having an approach which depends less on that is also something that is appealing. I mentioned cost because cost matters. Anything that we try and do in terms of training or mental health care has a cost and a burden associated with it. And if we can diminish those costs and increase access, the more likely we'll get more help to more people. Guided self-help, I'm going to say just a little bit in a minute. Maybe I'll just pause now. What this approach is, guided self-help, it's basically an approach that facilitates parents learning or an individual's learning how to help themselves with some guidance with a professional, but not a full-on kind of therapeutic hour. It's been shown to be helpful with a range of mental disorders in adults. It has been shown to be useful for binge eating disorder in adults, but few studies have explored parents targeted to use guided self-help strategies to help their children. One of the things that we found during the last 2 years of COVID is that when we got shut down, we were able to pivot rapidly to providing FBT online. Now, it turns out that I had already been doing this with the idea that this would provide increased access to people who are not able to get to specialty centers. I was working with a Canadian group, which I'll talk more about that in a few minutes. So we were well prepared from an FBT perspective because we already were delivering FBT online. And what was interesting is that we ramped it up, of course, and we found that FBT was acceptable to most families, and that once people got the hang of the technology, we all got Zoom experts, and we got much better at the use of video conferencing as a strategy to do therapy and therapeutic work. We actually have found that the outcomes look extremely similar, not really different at all, and FBT when it's provided by video conference or not. So that's promising about the use of video conferencing as a strategy. And what we had done already, again, prior to COVID, we had been thinking about this issue. We had developed a set of online videos, short videos, 1 to 3 to 4 minute videos that families could watch, parents could watch, and then some reading materials, mostly from the Help Your Teenager Beat an Eating Disorder book, and developed a kind of course, as it were, of materials for parents that a coach would help them discuss and raise questions about. So it wasn't really a therapy session. The material on the videos was about how to help your child. It was with in this case, Anorexia Nervosa was the targeted diagnostic group, and the videos were done by an expert clinician, and who was absolutely point on in describing how and ways to be helpful, and was therefore quite accurate in terms of how to help a family with these things in terms of being adherent to the FBT model. So we started a pilot study of these videos and this coaching strategy in about 2015 or 16, and we published the pilot study in, I think, 2018. So it was an open enrollment. We just advertised this study, and 19 families with a son or a daughter with anorexia nervosa were recruited and treated in this pilot study. And here's what we found, just to say this, that the materials are given to the families, and they're released on a weekly basis over 12 weeks, certain parts of it covering the different aspects of FBT. And then the therapist or coach would meet with the family once a week for 20 minutes to discuss what the videos had to say. And then the families would take the information and what coaching they got and proceed to manage at home. And what I want to show you here in these two graphs is, the red line is what we have from our average from randomized clinical trials. So the starting weight is usually around, around 82% here in those trials of expected weight for height. And then in this group, it was 85. So they were a little bit, they weighed a little bit more than the average patients starting our treatment. At the end of their treatment, which was the follow at the end of the 12 weeks, or about 3 months, you can see that in the typical average randomized sample, they got to around 93, 94% of expected weight. And in the guided self-help version, they got to about 97%. And then at follow-up, you see that the randomized average population got to about 94% on average, and the follow-up to the guided self-help stayed about the same at 97. Now, these aren't randomized outcomes, so I'm not really saying these are comparable, except to say that the pattern of progress looked good in both groups and looked similar to what you would expect. On the cognitions related to eating and weight, that's the eating disorder exam, you see here that the cognitions actually at baseline were much higher, because high is bad on this, in the group that were in the guided self-help group than they were reported in the group that were randomized. This is very interesting because one of the things that happens in the interview is that kids with anorexia often deny that they have symptoms. So these scores are usually artificially lowered. Whereas on these, because these were done online, they may have been more honest. In any event, you see improvements here and improvements here across the board. So the pattern, again, is similar. So what we learned from that was that in that pilot case series, at least, families were accepting of it. Very few dropped out, only one. And that the comparison to historical FBT patients looked pretty similar. However, these were self-selected, highly motivated families to use this particular platform. So they're non-representative of the usual clinical family, and it's a small sample, 19 people. So that led to our next question: are non-self-selected families willing to be randomized? You know, if you're a family and you go, well, I can get FBT or I can get guided self-help, am I willing to take that chance and be in a study? And what do we find if we find they are willing? So we conducted this study. Again, we had started this study pre-pandemic. This particular study was done with 2 sites, one here at Stanford and one at McMaster University. And all the treatments were done by video conference. There were 40 adolescents and their parents in this study, 20 at each site, and they were randomized. So the families agreed to be randomized to guided self-help or FBT via video conference. And really what we wanted to know was, could we recruit? Would people stay in the treatment? And did the outcomes indicate that we would get reasonable clinical changes that we would expect comparable in both groups? The other thing we wanted to know, and which is important here, is, what was the impact of the therapist's time? So it's there in that secondary outcomes bullet, efficiency. So essentially, therapists were putting in 1/3 the amount of time that they would in a typical case, because 20 minutes versus 60. So this gives you an overall look at this, what they call this a consort figure in studies, and it tells you the flow. So you can see here how many came in initially. We had 39 excluded, and the reasons for that were some were at too high a weight or too low a weight to be treated in the study. And 17, and this is the important number here, were eligible but not interested. So it wasn't a terrifically high number. 46 were screened by interview, and 6 were excluded for these same kinds of reasons. And then 40 were ultimately randomized. And you can see here that there were very low dropout, 1 study dropout and 1 treatment and 2 treatment dropouts. And the difference between that is study dropouts gave us data and treatment dropouts just did not complete treatment. So there were 3 overall here in this arm, and this was FBT provided by video conference, and there were 4 over here. And so not much difference between the 2, one participant. So that's important, because one of the things that we wanted to know was, were people acceptable, if they started guided self-help, even if they agreed initially to be randomized to it, would they stay with it? And they did, with similar dropout rates in both arms. And those are pretty similar. So this just tells you about what kind of kids they were. They were about 14 and almost 15. They were mostly young women, 85%. 4% were Hispanic, 2 Asians, 2 Asian, more than one race, 2. And these, I just want to point out here, this is a low range of ethnic diversity. Part of that's due to that being half the subjects being from Canada, where there was less diversity in their sample in Toronto. Most of the families, consistent with our data and most of our other studies, were still married. The parents were 75%. Overall, you can see the families were fairly well educated, college and postgraduate education. Again, not unusual in our samples of children with anorexia. So what happened in terms of their outcomes? And I want to just walk you through this slide a little bit. And what we find here is that on percent estimated body weight at the end of treatment in FBT, it was 93% versus 91% in guided self-help. And at follow-up, it was 94% versus 93%. For the EDE, the global score, which is the average of all the subscales, you see it was 1.56 in FBT. It's a big decline from 2.89 to 1.56, and from 2.99 to 1.54. Very little difference here. And at follow-up, 1.79 and 1.41. So on these measures of weight and cognition, the performance of the 2 kinds of FBT was the same. Looking at the Beck Depression Inventory, again, you see improvements in both. It's 13.8, which is down from 19, 22 to 14. And again, 14 to 11. So you're not seeing big differences, but substantial improvements. The Beck Anxiety Inventory, again, 19 to 12, 22 to 11, and then 16 and 11. So overall, again, improvements across time in the comorbidities of depression and anxiety symptoms. And this, parents, we wanted to ask how parents felt about their effectiveness. And this is a measure of that, parents versus anorexia nervosa scale. So we asked parents how effective they feel at refeeding their children. And they start off pretty similar. And the scores are 20, and then 22 and 24, and 21 and 23. So they improve as we would expect, and they improve similarly in both treatment arms. Hospital use is 22 days in FBT and 19 in guided self-help. So again, kids who became medically unstable during the course of their treatment were hospitalized for that, and that represents the number of days that were, and again, no difference between the groups. And this just gives you a little bit of the statistical meaning of this. And what something called a D is, what that basically means is what's the meaning of that statistic? How significant is it? And 0.3 means it's a very small difference. 0.1 means it's a very, very, very small difference. So these would be negligible differences in terms of interpretation of a statistic. And again, here, negligible differences. So these on BMI and percent, whether it's BMI or percent body weight, you're getting very clear indication that not only did the numbers look the same, they're statistically extremely similar. They weren't significantly different, and the effect size was very small. So this slide is really important one, and I want to walk you through it to help you understand what this is. This is therapeutic efficiency, and what I'm getting at in this slide is this is the end of treatment, and this line is this line is time, and this is the number of hours per unit. This is an efficiency score. And so here on the eating disorder exam, at the end of treatment, you have the similar outcomes right here, 1.43, 1.45. It took 13.3 hours of clinician time to achieve that in FBTV, and 3.9 hours to achieve that in guided self-help. At follow-up, 3 months post-treatment, 1.8 was the score, and 1.22 was the score. And in that one, it took 33.9 hours to achieve that, because you don't have any change that in that, and 13.3 to achieve that. So you see that it's, from a time point of view, much more efficient from a therapist's point of view, time-wise, in guided self-help than it is in FBTV. This is for weight. Again, you have a percent change, 9.79 in guided self-help and 8.63 at the end of treatment, 13.3 hours, 3.9 hours. Then you have a 12.8 at follow-up, the same amount of time, 9.97, almost 10%, same amount of time. So what these tell you is that you get similar outcomes with much less therapist time. So what to make of that? So now, if you think about this, you go, okay, well, you're getting similar outcomes in these two groups. This means parents are being as effective at learning how to help their child with 20 minutes of coaching over 12 sessions as they are in 20 sessions of an hour. That's an important difference, right? Families are spending a lot more time directly in therapy and spending more time in that arm, and the therapist spending more time. So what is it necessary? Well, it looks like in this preliminary study anyway, you don't really in all cases need to do that. So that's very important, because it means that in principle, maybe some families could use this approach, and it could make therapists time available to treat more people. And also without, as far as we could tell, any impacts on outcome. In other words, they got the same kind of outcomes. So that's really important as a possible thing. Well, it's not a conclusion that we can wrap our hands around and say, oh, that's definitely the case. It's instead the opposite of that. It's a indication that maybe there's something here to further research. When I was discussing these preliminary data at a meeting, Tracy Wade, who is a psychologist in Australia, asked me if she could potentially do research using these same materials. That they had a huge wait list in Adelaide, Australia, which is where her university is. And I said, sure, if you're going to do research, let's see if it can be helpful. So she collected a sample of adolescents. This is just a series, case series, not randomly, but just a case series of people who were on their wait list, and offered them guided self-help while they were waiting to get into care. And one of the things that was really interesting, and perhaps some of you will have some insight into this as to why this would happen, but only 10% of those who were offered this option took it. Now, they weren't getting other things because they were on a wait list, but they weren't willing to do this guided self-help, even if it was the only thing they were getting, only 10%. So 90% of families didn't want to do it. Those 10% of families that did do it, though, they stuck with it. So I think they had one drop out, and actually the kids did very well. The kids gained weight and had improvements on their eating cognitions and behaviors. So that, as you may know, around the world now, part of the things that happened with COVID is we had a huge uptick in referrals for eating disorders. Initially, there was like a flattening, and there weren't no referrals. Families were anxious about taking their kids to the doctor, and so on. And so but once they did start coming, there were lots and lots of new cases and more cases than we'd seen before. No one truly has explained what that is about. My own view, and perhaps some of you have some thoughts about it, is that vulnerable people with too much time on their hands and not other things to do, young people, turned to cope with their situation by focusing on weight and eating healthy and things like so-called eating healthy, in order to manage themselves in that context. And that led in vulnerable people, too many cases, to developing an eating disorder, and specifically anorexia nervosa. At the same time, I mentioned Jennifer Couturier earlier as one of the co-authors of the feasibility randomized trial that I just discussed. She also wanted to look at her wait list and see if guided self-help, the materials could be used for that. And so she again offered this, and this time in Tracy Wade's study, she offered coaching. So there was a coach, a psychology graduate student provided coaching. They were trained by us in how to coach, but they were not highly skilled or experienced clinicians. In this case, Dr. Couturier did not provide any coaching at all. She didn't have the resources to provide that. They were overwhelmed taking care of kids. So she said, you can have the videos and the reading materials if you want. And so she provided those, and about I think it's 30 families took her up on this, and it was offered over a period of time. Her take-up rate was better. It's 30% instead of 10. It's still, this was in Canada, so they have a national healthcare system there. There were no other treatments that these families could easily access, so it wasn't as if they could have alternatives. But again, 70% of the families did not want to do this. They were for unclear reasons, and 30% did. And again, though, those 30% that did stayed in the treatment, dropout was low. And really, they made great gains in terms of weight and also eating related cognitions during that waitlist treatment period. Her study design was interesting. She measured families over a period of a 2-week period, and then for changes, and then Then she offered it and looked at changes for the next period so it's the same cohort design comparing families. So guided self-help may be a promising new way to increase access to care, and but all the current studies are small numbers. So if you think about the 19 that we treated in the pilot study, and then the 40 in the feasibility study, and then the 30 in each of Tracy Wade and Jennifer Couturier studies, you're talking, just over 100 total people that have been studied so far. Only one of them was randomized. The study that the feasibility study that I described. When the materials were developed, which was in 2015 and 2016, the way that we conceived of it, the therapist who presented the materials was a very typical expert in eating disorders. That's a white woman psychologist. And this view of this angle has limitations for acceptability, maybe in other populations. So we want and are developing scripts and re-recording some of those videos with different ethnicities and cultural groups presented. As I mentioned, both in Australia, Canada, and even here, the diversity of the participants is quite limited. So we're not sure how participants from different cultural, ethnic, and SES backgrounds might fare. And we think that's an important possible variable in terms of who is likely to benefit from guided self-help. And we're trying to address it in some ways. And there were relatively few therapists that were participating in these studies. But even in those small number of therapists, there was a fair bit of skepticism on the part of the therapists initially about this treatment, and it required of them to behave very differently than they would if they were in a typical FBT session. Because again, you're helping people learn from the materials rather than actually intervening as if you were a therapist in a family session. So it's a very different skill base, and in some ways easier, but in any way, event quite different from what you might expect most therapists to do. And so therapists are skeptical and also a bit concerned about their role. So, these are temporary conclusions kind of things. Guided self-help shows promise as a treatment to increase access, lower costs, and improve outcomes as a result, overall outcomes. But larger studies are needed to better understand if this treatment is effective compared to standard treatment and determine who is most appropriate for this type of intervention. And in technical term for that, who's most appropriate is moderators. What kind of baseline characteristics might matter. How long the patient's been ill, how underweight she or he is, what the status of the family is in terms of its being family that is married and or single parent, or all these things. None of those things can be looked at in the small samples that we have gotten so far. So we can't begin to understand that. And those things could matter a lot. So next steps, we were lucky that the NIMH saw fit or is seeing fit to fund us to do a fully powered study, 200 families, comparing guided self-help FBT to FBT, 100 in Canada and 100 in the US. It was just funded. And so we're very excited about that because it will allow us to actually look at substantively whether this treatment is effective. As I mentioned, we do need to refine the approach to make it, there's materials that, as we've used to the materials, we said, well, we need to make these changes in them. There's some things that are missing and some things we want to change, particularly around diversity. And we need to address and figure out more about these implementation challenges around therapists and their uh, and parent acceptance. You know, we didn't have so much a problem during COVID, maybe because maybe parents were more accepting of this as a possibility. Their options were fewer. That may still be the case moving forward because the demand is so much exceeds the current capacity, but it may not be a preference, and we want to understand those. And I'm often asked, you know, why don't you just make this available right now, instead of studying it further? And and the reason is because I worry that there could be harms to this that I don't know yet. It's you know, with so few people treated, and a good chunk of them are people that were specifically wanting to use this kind of approach or willing to. And so making it available generally without knowing better who maybe shouldn't do it, that it could be harmful, is something that I think we need to better understand. And this larger study should help with that. We also need larger scale studies for guided self-help as a wait list. Again, um, if you have nothing, trying to get you started as a family while you're waiting to get further help seems to be logical, but it also seems to be problematic, and many families seem ambivalent or uncertain as whether that's the right thing to do. And and so, from my perspective, anyway, I would love to see a large-scale waitlist study in a healthcare system, and I'm trying to identify a researcher to do that. We're pretty busy. I don't think it's something that I personally can take on in my lab now, but something I would love to see another research site do. And with that, I think I've left enough time for discussion and questions, as Judy asked.
Thank you very much for your presentation. So just a comment and then a question, or maybe two. So three different parents commented when you were asking about the low recruitment rate. So different parents said that they think that it's possibly because parents are terrified of doing damage, saying or doing the wrong thing, and fear of failure. So, you know, that's definitely something that, you know, this group feels may contribute toward the low numbers that you're referencing.
You know, I think that they're spot on in terms of my own understanding about why families would be hesitant. They have a very sick child, and they don't know what to do. It's confusing, and so the hesitancy is really understandable. They don't want to do, don't want to do harm. So one of the interesting things that we've thought about, at least in terms of encouraging families to consider it on a wait list, is to have families who have used it comment on it, and say how they benefited from it, and getting some comment from, as it were, the source, you know, that this actually was helpful. Don't be so frightened of it. So but I do think that's right. That's at least one of the reasons why. Some other people have suggested that people are afraid that if they do this, they'll somehow not get prioritized for other treatments and so forth. And even though that was not the case in either Dr. Wade's or Dr. Couturier's study, it could have been feared that, oh, if I do this, it's going to take me longer to get into real care.
And what do parents do if they have questions? Meaning, you know, obviously this is FBT in any form, I think we could all attest, is extremely difficult. So if parents are doing, you know, self-guided FBT and they have questions, is there a place that they can address those questions?
Yeah, so there is a coach for 20 minutes every week. So that's what happens. So the parents will look at the materials. They might try and do the kinds of things that are suggested, and then the coach would process their questions with them. I
Um,
think if I understood the question.
okay. Yes, that was the question, but you had said that the coaches are students, meaning the coaches are not, they're not FBT therapists. They're not on the same professional level as non-self-guided FBT, if I understood you correctly.
Well, that was in Tracy Wade's study on the wait list. She had graduate students who had been trained in the materials and knew how to answer questions. But in the feasibility study and in the pilot study, they were psychologists who were trained. So each study had a slightly, and then in Jennifer Couturier's study, the one in Canada, they didn't have any therapists, so the families were on their own. And if they had questions, they didn't have any. There was no one to respond to them. So that was truly self-help, not guided. That was truly self-help. Um, in the big study that we're doing, we're having mental health professionals, but not expert FBT therapists do the coaching. And why we're doing that is because we want to know if we can train to a certain level clinicians who are not highly expert to still be helpful, because as I pointed out, the pipeline of true experts is so slow. If we really want to be able to implement it, we need to be able to have other kinds of clinicians use it and be helpful.
Are you measuring the differential in the parent experience um, between guided self-help and regular FBT?
Yeah. So one of there are the parent self-efficacy scale that I mentioned it on the feasibility study. That's a parent experience scale. How effective they feel at refeeding their children. And I didn't show this uh, on graphic, but if you look at those scores, interestingly, the parents in guided self-help actually felt more self-efficacious than those that were in in FBT. And not a great deal more, but they did. And if you think about it, how I make sense of that is the parents actually were doing more on their own. So they did feel more like they were competent, and were supported in that through the materials and also the coaching.
Okay. Um, Someone asked, were there any psychiatric admissions? And I want to piggyback on that. I mean, obviously this was a very small study, and you chose very specific parameters for this study for obvious reasons. But I was curious, did any of the people in this study have any comorbid conditions? Did you filter those out? Like, how did the psychiatric side of this play into the study, if at all?
So no, the study allowed anyone to enter the study that was medically stable and not psychotic and could speak English. So there
Okay.
were no filterings of that. And that's true, by the way, of all the FBT studies that we've ever done. So we've never eliminated people who have anxiety disorders, OCD, depression. None of those things are, or suicidality. None of those things are eliminated from our studies. They're always allowed in. And in this study, there were 2 hospitalizations for psychiatric reasons, one in each arm. Out of the so in those days, those are captured in the number of days in that were between the 19 and 22, I think the numbers were. So it was a very small number, and it's pretty similar percentage-wise to what we would have found in a randomized trial, that there are a handful of psychiatric admissions out of the cohort in each arm. And usually those are for suicidal behaviors.
Okay. Thank you. some of the questions aren't questions. So FYI, I see them all. Those that are questions I'm trying to ask. I actually want to go a teeny bit off topic because it's really such a great opportunity to have you here with us. And so many of our parents do use FBT. And I wanted to ask you on a personal level, you know, FBT is revolutionary in believing that parents are capable and competent and able to actually support our children's recovery in the home. And I just kind of wanted to ask you, I'm sure there are people who are here with us today that can really use some words of support. And I was curious, you know, what powers do you think parents have, or why do you think parents are so well suited to do this work?
Well, so it is. It's, you know, when the work we started here at Stanford in 2000, when we manualized the treatment and started doing the first studies in the US, and the first manualized studies ever of FBT. Daniel LaGrange and I were ridiculed rather a lot, I would say, by professionals in the field who had a view of families which was historically based on a very biased perception, and one that neither of us believed, and nor was it our experience. We understood families were distressed and in crisis, but we didn't see them as not being able to be helpful. And so that was a big change, and it took many years. And a lot of that came, I think, from the history of looking mostly at more chronically ill adults with anorexia nervosa, rather than focusing on younger patients who were 14 or 15 when the illness typically onsets. And so that focus on younger patients earlier in the course and families was a huge shift, and allowed us actually to develop the first really effective treatments that we have for anorexia nervosa, because FBT still is really the only one that has demonstrably treatment effects. So the question more broadly, you know, why do I believe in families? Well, when I started, I didn't know. They've shown me during the first trial. My whole team was deeply suspicious of the intervention, and as they saw that parents actually were so invested, which is not surprising, in their children, and so caring, that they're and so effective in being creative and solving the problems that the child presented. It's one thing you have a whole nursing staff, you know, of three shifts a day and all these different people. You can get kids to gain weight in the hospital. That's not even difficult. The problem is it's not an environment where the learning can be generalized. You can't take that weight. If it did, I would just say put everybody in the hospital and cure them and get them out. Doesn't work. Never has. We've done it for 100 years. It doesn't work. And it's basic learning. Families are where the children have to eat. They have to be in their homes. They have to eat what their families eat. They have to eat with their friends at school. That's how you get better. That's how you the learning of managing your anxieties and worries about these things gets confronted and changed. And parents are the ones who need to help. And who can. As they do for kids who have any serious medical problem, whether it's diabetes or cancer or anything, kids at 14 are not self-sufficient agents. They are not capable of managing their own affairs. Anyone who has a 14-year-old knows this. They can, mostly they remember to put the right clothes on, but it's not developmentally inappropriate for parents to be helpful when there are big problems in teenage life. So normative, the environment is the one in which learning needs to take place. Parents are the most invested in their children and will go the extra mile more than any professional ever will or can. I hope those comments are helpful. That's why I believe in parents, and they've proven it to me. And what guided self-help shows me, as well as across the time, is the more, the better I understand what parents can do, and support them in doing it, they demonstrate more and more that they can do even more. Because guided self-help, that's even less professional, right? So parents are even more showing me we can do this. And I believe it because I've seen it.
Well, thank you. There's a sentiment from many parents here, just saying thank you for believing in families and for being our advocate, because and someone just said that your words give hope. And I think that we all know that, hope is one of the most important components that, gets us out of bed every day to do this feeding and to take this journey. So thank you very much for this. Thank you very much for the webinar. I think it was extremely informative. I wish you a lot of good luck going forward. And I really hope that we have the opportunity to all benefit from guided self-help if appropriate. So hopefully it will be available to the masses sooner rather than later, because, so many parents are waiting for treatment. And it really is so critical, that early intervention piece. It's a horrible thing to miss the boat because you can't get treatment. So this really is a ray of hope to those who are waiting for treatment, with the knowledge of that, once it becomes more widely available, it will be something that parents can use. So thank you very much for this.
You're welcome. Can I just say
Go
that that study, which will begin recruitment in January, will be a national recruitment. So FE.A.S.T parents who aren't in care can, or people who contact FE.A.S.T who have an eligible son or daughter with anorexia can be a part of that study. Right now, as soon as we start, and we're just putting together the final consent processes and all that's required that you need to do for safety. But fundamentally, yes, it's available now. And thank you for those really
make
kind
sure to send it
words.
to us at FE.A.S.T so that we can publicize it.
Yes.
Because we do get a lot of people in our community who participate in research happily, extremely happily. We're happy to do our part. So please, when you're, recruiting people, please do send it to us so that we can help you with that recruitment. I just wanted to end by letting everyone know that FE.A.S.T programs are free. This webinar and other programs like it can only be continued with the support of our community. So if you have a minute to go to our website, and if you are able to donate, anything you can donate would be really appreciated. And we look forward to seeing everyone again next month. We will be hosting Therese Waterhouse, and she's going to be talking about nurturing your loved one with an eating disorder through the holiday season, which is an extremely relevant topic for so many parents, and we really hope you'll join us. So again, thank you everyone for joining us today. Thank you again, Dr. Locke, and we hope to see you again next month.
Bye.
Bye.